There are many factors that went into making this decision, including PCV13's effectiveness against IPD, including pneumonia with bacteremia, and PCV demonstrated efficacy against vaccine-type non-bacteremic pneumococcal pneumonia, or NBPP, as noted from the CAPITA trial in Tamara's presentation. From this, we wanted to know what is the burden of NBPP and what is the impact of PCV13 on NBPP for adults 65 years and older. Strep pneumo is a common cause of community-acquired pneumonia, or CAP. In a meta-analysis using pre-pediatric PCV13 introduction, before PCV13 was introduced for peds, it was estimated to cause 27% of CAP. However, figuring out CAP incidence attributed to S. pneumo is very difficult. Because blood culture has low sensitivity, it is thought to detect about 25% of pneumococcal pneumonia cases. Additionally, pneumococcal urinary antigen test, referred to here as UAT, which has a pooled sensitivity of about 75% and a specificity of 95%, is not universally available or routinely used by all providers. And it should be noted here that when I'm talking about UAT, I'm talking about the commercially available UAT, which is different than the one just presented by Pfizer, the SSUAD, which can determine serotype. To put some studies in context, I have mapped those with an adult incidence reported here. The hashed lines are studies that reported a pneumonia incidence and for which I have calculated a pneumococcal proportion using the 27% in the previous slide. Solid lines represent measured pneumococcal pneumonia. So going chronologically through this slide, STORMS, using discharge codes from vaccine safety data link sites, had a calculated pneumococcal pneumonia incidence of 108 per 100,000. U, also using discharge codes, but from US Medicare Part A beneficiaries, so a population in which younger adults would have only been eligible if they'd been disabled or had another qualifying medical condition. I calculated a pneumococcal pneumonia incidence of 462 per 100,000. BWIC measured a pneumococcal pneumonia incidence of 37 per 100,000 in 2008 to 2010, using culture and a serotype-specific UAT for UK adults admitted with pneumonia. A follow-up study published by Rodrigo had an incidence of 21 per 100,000 post-pediatric PCV introduction using the same population and methods. And a study already referenced earlier today, JANE, the EPIC study, measured pneumococcal pneumonia incidence using culture, PCR, and UAT to be 12 per 100,000, which was 5% of CAP in this study. Lastly, Ramirez, from the preceding presentation, a calculated pneumococcal pneumonia from the study would be 171 per 100,000 for all adults. Given that background, a surveillance for non-invasive pneumococcal pneumonia, or SNIPP, was set up to describe invasive pneumococcal pneumonia among adults, estimate the burden of non-invasive pneumococcal pneumonia, and eventually examine the potential impact of the 2014 ACIP recommendation for routine PCV13 amongst adults 65 and older, though we will focus only on the first two bullets today. Briefly, SNIPP is built into the active bacterial course surveillance, or ABCs. Cases are defined as adults 18 years or older, hospitalized with clinically or radiographically confirmed pneumonia and a positive pneumococcal UAT. Cases are excluded if they have IPD or another positive pneumococcal UAT within 30 days. SNIPP has been running prospectively since 2015, and retrospective data was collected going back to 2013. Again, today we will focus on the pre-65-year-old PCV period of 2013-2014. UAT positive cases captured by SNIPP in this time period, half were 65 years and older, most were diagnosed within 1 day of admission, almost all had radiographically confirmed pneumonia, and a third were admitted to the ICU. Because we know that not all suspected pneumococcal pneumonia cases are tested by UAT, we adjust the UAT case count by the proportion of pneumonia tested by UAT at that hospital. This information is obtained from hospital discharge records and clinical labs. Additionally, we know that not all hospitals use UAT. To address this, we adjust UAT case counts by the proportion of pneumonia in the catchment area that was seen at the hospitals offering UAT. This information is obtained from hospital discharge records and county-level discharge data. A bit more about these adjustments. A sample of hospitals within the catchment area are selected. Currently included in this presentation is 22 hospitals. At each of these hospitals, a random selection of 20 pneumonia discharges per age group per month is made. We define pneumonia discharges similar to many of the studies before by a first discharge code of pneumonia or empyema, or a first discharge code of sepsis with pneumonia or empyema elsewhere. We have the pneumonia discharges in the catchment area seen at hospitals offering UAT for all hospitals. There are 37 hospitals now included in 7 urban areas. These hospitals represent public, private, teaching, university, small and large, though the majority are of a medium size of 200 to 500 beds per hospital. This slide shows UAT cases, the adjustments, and the catchment area population by site. Over the 2 years, sites reported between 9 and 550 UAT positive cases. In part, this wide range is due to testing practices. On average, 32% of pneumonia discharges are tested by UAT during their hospitalization, but the range is from 2 to 72%. The average percent of pneumonia discharges seen at hospitals offering UAT is 41%, with a range of 11 to 83. The crude incidence based on reported UAT positive NBP cases only would be 6 per 100,000. A very preliminary annual incidence estimate using the described adjustments, we get 99 cases per 100,000. Because we have seen such a difference in UAT testing practices, we looked at the estimated incidence by percent of pneumonia tested. As the percent increases in this table from 10 to 50, there are fewer hospitals included, but the incidence stays relatively stable between 79 and 97 cases per 100,000. There are several limitations in SNIPP, including missing data from hospitals and laboratories. As is the case with many previous studies, we are reliant on administrative codes for our adjustments. We use a sample of hospitals and then a sample of pneumonia discharges within these hospitals to determine the proportion of pneumonia tested by UAT and see variability in the testing practices by hospital and sites. Because of these limitations, we wanted to check our incidence estimates using all pneumonia discharge codes, similar to the calculations I made for the background literature. Taking all pneumonia discharges from the SNIPP catchment area, we have 440 pneumonia cases per 100,000. Assuming 27% of CAP is strep pneumo, we get 120 pneumococcal pneumonia cases per 100,000. And from the SIED meta-analysis, we can estimate that non-bacteremic pneumococcal pneumonia is 3/4 of all pneumonia, which brings us to 90 cases per 100,000 as compared to the 99 using our adjustments. Putting this in perspective with the other studies, the 2 SNIPP estimates are here in black. We have several next steps planned, including complete data collection and cleaning, model the proportion of patients with pneumonia discharge diagnosis from hospitals not sampled, tested by UAT, determine the age-adjusted annual incidence, and compare incidence in 2013-2014 to 2015-2016 to look at PCV13 impact. And we are also open to any thoughts you have on ways of improving surveillance for NBPP. Before I move on to the summary of the progress and research agenda, I'd like to acknowledge and thank the many people involved in this project. Moving on, progress of the research agenda for potential policy change. To reiterate the questions that have been raised, in light of indirect effects observed, what is the impact of direct effects of PCV13 on pneumococcal disease amongst adults 65 years and older? What benefits would we expect from continued PCV use amongst adults 65 years and older? Focusing on adults 65 years and older, the evidence presented to date is that pneumococcal carriage amongst adults 65 years and lower is very low, with PCV13 carriage at 0.2% in 2015 to 2016. PCV13 coverage amongst adults 65 years and older is around 40%. It is lower amongst 19 to 64-year-olds, but varies by indication. And since this was brought up before, I do have the numbers here that are based on sales data from Pfizer. Amongst HIV positive adults 18 to 64, it's 34% in the last year, so 2017. With hematologic or metastatic cancers, 20%, to give some range on some of the adults that we think have conditions that put them at very high risk. PCV13 IPD has decreased in all age groups. Incidence in adults 65 years and older plateaued in 2014 to 2016. Modeled direct and indirect PCV13 effects on IPD in adults 65 years and older projected relatively few cases, as you saw earlier. And it has been noted that serotype 3 IPD doesn't follow the same pattern as the other PCV13 types. Putting here in perspective the VE that has been presented from Capita, a randomized controlled trial of adults 65 years and older, it was 75%, and today's two studies, 65 and 47%. This includes the serotype 6C for the latter two. And then the VE against PCV13 type, pneumococcal pneumonia, from Capita was 45%, and as you saw presented today, around 73%. At upcoming meetings, we plan to continue updates about PCV impact on pneumonia that we have from SNIPP, as well as other ongoing studies. Model estimating public health impact and cost effectiveness of different policy options, including no PCV13 recommendation for adults 65 years and older, and expanding indications for adults less than 65 years old. And this brings me back to the discussion question. What additional information will the committee need to help determine whether continued PCV13 use amongst adults 65 years and older is warranted? So thank you again.
Thank you very much for that great summary. Questions? Yes, Dr. Hunter.
Regarding the discussion question, my understanding, I wasn't here at the time, that the vote in 2014 to vaccinate adults for PCV13 was in part based on a cost effectiveness analysis that heavily weighted non-bacteremic pneumococcal pneumonia. And two questions about that. I'm assuming there's been a change in the price of the vaccine in that time. I don't know if that's correct or not. And number two, is there going to be a consideration of redoing the cost analysis?
Thanks. Yes, so we will definitely be updating the cost effectiveness analysis. I guess when I said modeling public health impact, it goes beyond just the cost effectiveness, but that will be included in that And we will update it with new information that we have about pricing as well as pneumonia incidence and impact.
Just to be clear about that, when we did the original cost effectiveness analysis, the biggest factor was the disappearance of vaccine serotype disease. And we knew that that was going to, we actually projected out the cost effectiveness for 2019. And that was a huge factor. Dr. Lee.
Just a comment that the estimates with the 27% pre-PCV13 would be sort of your highest estimates, because we just saw today that pneumococcal, the proportion of community-acquired pneumonia attributed to pneumococcal infection and PCV13 type specifically is substantially lower. So 3 to 5% is what we saw today. So I think that those estimates might be higher.
Yeah, thanks. I think that's a really important point. And since I only had today to present overall adult estimates for SNIPP, I limited what was presented here to overall adults. But we definitely know that the incidence is higher amongst older age groups. And from previous studies, we think as well the proportion does change in older age groups versus younger age groups. And so when we can do that more full presentation, we will. Yeah, but that's an important point. Thanks.
Other? Dr. Quash.
Yes, thank you. I was wondering in your SNIPP study if you had any understanding of the practices for ordering UAT, because it might not be completely random, and you might have some selection bias into, you see a patient who looks sicker, you might want to ask for it, and so I'm not sure that just adjusting the way it is being done is what needs to be done. I don't know if you had looked at that.
Yeah, we're working and will present what we know about the variation in UAT testing practice, but you've seen right into it, so thank you for bringing that up, that we think that that is a consideration, but don't yet fully understand how it's impacting our numbers.
I have one additional question. What are the possibilities for having a serotype-specific UAT commercially available anytime in the near future?
I don't know.
Just thought I'd ask.
Yeah, that would be really helpful. I mean, so far the UATs that are serotype specific look at vaccine type, which of course is of interest to us, but it would also be of interest to know the other serotypes as well, knowing that in IPD we see such a decrease in vaccine type that, is the pneumonia that we're seeing still vaccine type, or if it's not, what other serotypes are causing pneumonia?
Thank you. Dr. Mastoni.
Yeah, I would just point out, though, that we need to be careful in interpreting the Pfizer assay, which is set up for surveillance, which is hugely important from a public health impact perspective, but really the evaluation of whether it would be important for clinical decision-making is actually a very different evaluation.
Yes, Dr.
So,
Bray.
right now the recommendation is to start immunizing at age 65. Is there any efforts to try to look at duration of protection, since the mean ages for the pneumonias were in the 70s, and do we know if somebody's immunized at 65 that they will still maintain adequate immunological protection?
Yeah, I'm not sure I'm the best person to fully answer that question. We do know that it was looked out 4 years in the Capita trial, but beyond that, I don't know what the most updated thing is. Cindy, do you have any other?
I don't think we have a great way to look at that with our methodology, but I would agree we could, I think it might be a better question for Pfizer.
Dr. Stevens?
Related to that question is actually when you give the conjugate. Do you give it earlier and then boost, for example, with the polysaccharide? I think some of those questions about timing and in relationship to, because the over 65 may not, to the question that was raised, respond as well. So I think more data on the immunology of the conjugate and when you give the conjugate is important.
Thank you. Any other questions Thoughts? Okay, we are doing really well on time. I think we're going to take a break now rather than later. And could I ask you to all be back at 10:15?
And I just want to let everyone know that at 10:15, we will start the evidence-based recommendation session that was scheduled for yesterday, and then we'll get back onto schedule with our hospital-associated infections vaccines update.